a brand new episode of Ladyz Digest, where issues in the world of women are discussed. Ladyz Digest is proudly powered by AAU, the voice of higher education in Africa. In today's discussion, we will be discussing quite a common issue, which is no respecter of status or persons, and it affects both male and female. Remember, you can catch us up on our social media handles on Facebook and YouTube at the Association of African Universities, and on our Instagram handle at Ladyz Digest. Do stay tuned. I'm Johnny Kuyaiwa. Welcome back, and in my introduction, I made you know that this is Ladyz Digest, and I would want to start by just saying that about 85% of couples, upon getting married or trying to get a family, usually achieve pregnancy within the first year of trying. But then, if this doesn't happen, what do you do? What happens next? So today we'll be looking at infertility in women, and as I said earlier on, it affects both men and women, but then we'll be looking at infertility in women. And as usual, I have my gynecologist, my expert, to help us discuss this issue on infertility in women. Welcome, Doc.
Thank you. Happy to be here.
How's your weekend?
Oh, it was great.
And okay, you look good too.
Thank you.
Yeah, so we are looking at infertility in women, and
Yes.
before we start, I want like a statistics, because early on we talk about infertility, and we noticed that it's, I don't know if it's my eye noticing alone, we noticed that women, it's more common now than then for this issue of infertility. You see young couples getting married and then they are having issues or trying for more than a year and nothing is happening. So would you help us, like assist us with the statistics, the current statistics now compared to previous years?
Well, we know that for now, I don't have very exact figures off my head, but I know that for now, the problem is increasing because of multiple factors. Partly because some women are delaying childbirth because of career development and education as well. Yes, there's more investigation as to find out the cause. So usually the perception, particularly in a sub-region where the problem was, infertility was a problem of the woman.
Yes.
It's gradually changing.
Sure.
You know. So yes, it's become more, people have become more aware, and then and also increasing sexually transmitted infections contributing to tuberous disease also. Part of the reason why it's rising. Yeah. So yes, it's an emerging, or it's a pertinent problem in our
okay. So at least we've gotten that. So I will want, as usual, the very lay definition of infertility.
Well, it is defined as the inability of a couple to achieve a pregnancy in spite of regular and protected intercourse over a period of 12 months. Over a period of 12 months. That's a year.
Oh, okay. So we know that in every condition, there are usually underlying factors that put individuals at risk to that particular condition. So here we are talking about the risk factors. Would you be able to help us with some risk factors that affect infertility? And here we are talking about women.
Okay. Yeah. So as a prerequisite to achieve natural conception, or conception naturally, you are looking at having adequate or good sperm. Yeah. You're looking at having good tubes that work, because fertilization happens inside the tube. You're looking at having good eggs, or some ovulation happening on a very regular, consistent basis. Those are like the three basic things needed. Okay. So with regard to the factors, usually it's maybe 40% to the woman, about 30% in terms of male factor. And then 30% split across both. And then a small percentage which is unexplained, maybe 1 or 2% unexplained. So what that means is that in spite of all the investigations that we usually do, you will not find an obvious cause. So that is the distribution.
Okay.
But with regard to risk factors, so anything that affects sperm quality would be a factor in terms of maybe having diseases like mumps as a teenager that affecting the sperm, the testicular structure. Having certain exposure to certain chemicals that also affect sperm production. With a woman, we are looking at inflammatory disease or sexual transmitted infections that affect the tubes.
Okay.
We have people who have ovulatory problems, maybe PCOS, or for some reason ovulation is not consistent. Or we have people who have problems with their womb itself, either fibroids or adenomyosis or endometriosis, which also affects the tubes as well. So any of these can lead to having problems with infertility.
Okay. Yeah. Will lifestyle be one, or the weight of a lady?
Yes, with regard to lifestyle and weight, usually lifestyles may lead to increased BMI, so obesity with time, and then once become overweight, increased risk of having ovulatory problems or menstrual irregularities, alongside other comorbid, maybe blood pressure issues or blood sugar problems, diabetes, which can also affect, because all other medical conditions that are not well treated or optimized can also affect fertility.
Okay. Yeah. So in trying to address these factors independently, I know in your first, when we're talking about the statistics, and you mentioned like getting married, settling down late or trying to give birth late would be one. I would want to know, can one of them be a cause in general, or let's look at if you are obese, can that alone be a risk factor, or it has to be associated with other things?
That alone, yes, can be a risk factor.
Wow,
because it can present comorbid medical problems as well. But usually, some of them you have a combination of a lot of factors. So usually in our assessment, we try to find out whatever it's there, whether it's a tubal factor, it's an ovulatory factor, or it's a male factor. And then we'll try to solve. But yes, being obese alone can contribute to that.
Okay. So still talking about obesity, I want to look at obesity in children, first of all, because that's where a girl child develops. So obesity in a girl child, looking at, we know most of the times it's the food they eat nowadays, which is more like the lifestyle. What can be done about that, or can it start affecting them as children with regards to infertility?
Well, usually what happens is that the reproductive axis would mature after puberty. So usually a child that hasn't undergone puberty is not reproductively capable. Okay. So yes, if you're overweight in childhood, it has its own problems, and then it can also affect the hormonal balance. As you hit puberty. So then, for the woman or the girl child who's overweight, the biggest is hormonal imbalance with ovulatory challenges.
Okay. So it would be advisable to start watching the weight from like childhood to avoid.
Ideally, yes. To watch a child the weight from childhood.
Okay. So let's talk about the causes of infertility. What would be some causes of infertility?
Well, as I mentioned earlier, we usually, in terms of gross distribution, usually about 40% female factors, which subdivided into the tubal factors, factors that are attributed to ovulation or the ovary itself, and then factors are attributable to the uterus itself. Then we have the 30% male factors. For whatever reasons, male sperm or the sperm is compromised. And then we have 30% due to the both of them. Then we have a 1 to 2% unexplained. So commonest thing amongst the women will be the tubal factor, which usually has antecedent infections, pelvic infections from poorly treated sexual transmitted infections or other pelvic inflammatory diseases which are not well treated when it does happen, or multiple episodes of that, leading to compromising the tube and the tubal function as well. Or we could have problems with ovulation, which is where biggest example is the PCO, where the ovulation is not on a regular basis.
PCOS, yeah.
So those are maybe the top two problems.
Causes.
Then we come to problems with the womb, which is the fibroids, other problems like adenomyosis or endometriosis, which can also affect the womb as well.
Yes.
So any of them in a woman can be responsible for you not being able to conceive.
Okay, so I know you talked about menses, but I don't know with which context. I'm just wondering if I think I might early menarche, if it can in any way contribute to infertility. That's a lady getting and seeing a period early or earlier than should be.
No, early menarche is not really a risk factor for infertility. Okay. Once you undergo puberty and have your first menses, which is a menarche, you are reproductively mature.
Okay.
So you can get pregnant from that point.
From there, okay.
Yes.
So it doesn't.
So it's usually not a problem. Usually those with the late ones are those that may have challenges.
Okay, rather those with the late ones.
Because then usually there might be some underlying hormonal challenges.
Okay. And I don't know, it's something I know then, it's just what women say then, that because especially for the late age, because the menses or the eggs are used to always flowing as the monthly thing. So when maybe it's time for it to stay or get fertilized, it's not used to that thing. So that can be one cause of infertility.
Not really. The thing is a bit like clockwork in the sense that once your reproductive axis, as all the glands mature and you go into menarche, every month you get a number of eggs that are selected. So it's a process that happens without much control on your side.
Okay.
Till you get to menopause, where the sort of egg reserve or ovarian reserve is reduced. So it's an automatic process happening every month.
Okay, that's true. Okay, we'll go for a quick break. Yeah, this has been Ladyz Digest, and we've been discussing infertility in women. We talked about the causes of infertility, where we talked about the lifestyle, obesity, and all. When we come back, we'll talk about the treatments and other things. Do stay tuned. Welcome back. This is still Ladyz Digest, and we are talking about infertility in women. Remember, you can catch us up on our social media handles on Facebook and YouTube at the Association of African Universities, and you can follow our Instagram handle at Ladyz Digest. And we are still discussing infertility with Dr. Kwejo Owusu-Ansah. Welcome back, Doc.
Thank you.
Yeah, so I would want to talk about the symptoms. We know for most of us, we are almost all guilty. We usually don't go to the hospitals till we have an issue or till it has really gotten to a bad state, a state where we are worried about it. So that being said, I know the only symptom which I can think about will be you not giving birth or you not getting pregnant. But are there other symptoms of the same condition, infertility?
Well, it's very difficult to put it as symptoms because usually, as I said in the definition, we would come in if the couple have failed to achieve a pregnancy over 12 months. Even with that 12 months, you are looking at were they having regular unprotected intercourse. If they were having regular but it was protected because we were not ready, we had to really say this is infertility.
Sure.
So there are no obvious clear-cut symptoms to that. But usually when you see, probably in the African context and sub-region, when couples get married, there's nothing, then probably family would start sort of mounting the initial pressure and everything. But it could be it's a voluntary or mutual decision to delay childbirth.
Yeah, so it's when it's no more it's no more a decision to delay, and you say, okay, we are ready to start a family, and nothing is happening, and that's when, okay.
So even with that, once they start, we will give them 12 months.
Okay, you still give them some 12 months, okay, to try.
Unless the only catch is if the woman is advanced in terms of maternal age, we're looking at maybe 38 onwards, maybe 40. Then that 12-month period probably will reduce to 6 months, where you want to be investigating at the more earlier stage than usual. But yes, we give them 12 months. Because the reason we give 12 months is that what we've realized is that if you do give a couple having regular unprotected intercourse time, in 12 months, about 75 to 90% would have conceived. Without any intervention or
medical
help
intervention
from the medical person. And if you even give them an extra 6 to 12 months, another 4 to 5% would conceive.
Wow, I see.
So, but it's hard to convince patients that that's how the timeline works. So usually, in reality, about only 4 to 6% may need our help to conceive.
I see. After all the patience and all. Yeah, I see. Okay. Initially, in your early discussion, you mentioned the infertility in men, infertility in women, and then the unknown, which is a very little category. Can you explain that? What would be some, like, the features of those unknown, or what it's about?
So what we label as unexplained infertility would be the couple will come to you, you do a history, you do an examination, you do all your other investigations like ultrasound scan, you check for ovarian reserve, check their hormone levels, everything. In spite of all the best efforts, there's no clear-cut reason why they're not conceiving. That's what we label as unexplained.
So when it comes, but then for that aspect, treatments can be done for that.
So usually we would recommend straight up going for an assisted conception technique. Because it will be difficult to try and explain why naturally they are not conceiving.
They are not conceiving. That's true. Okay. So let's still talking about menses, because I think it's a very big factor to fertility or infertility. And we know that most times a lady, when you're having a period, you feel some ladies have some little menstrual cramps and all. And you mentioned endometriosis, and I know it's a feature of endometriosis has to do with acute pain. So, which can equally be a contributing factor to infertility. So, I would want to know when that pain, was the line between the pain of a normal menstrual cramp and endometriosis, where a lady needs to seek attention.
Okay, so usually for the woman who's never given birth before, you have some pain. Usually it's hormonal. It may start a couple of days before the start of the flow. But what you do realize is that once the flow commences, the pain intensity reduces. May last maybe first day, maybe at towards second day of the flow, and that's it. That is the normal for most women until they give birth. Then almost their periods are painless in most instances. Now with a woman with endometriosis, the pain may come before the cycle, may persist throughout cycle, and may even stay afterwards. And some too may have to go to hospital with every cycle. So if you have a woman with persistent pain before flow, during the flow, and even after the flow, or a woman who gets hospitalized with every menstrual cycle, those are the initial red flags to maybe want to investigate further. So this could be a possible case.
I see. To be hospitalized, that's serious. I see. Okay. So let's talk about diagnosis. So a lady comes to you, or a couple comes to you, and apart from the question, have you been having regular unprotected sex? In your investigation, what would be some questions and then some series of tests that would be carried out to really ascertain the issue?
Okay, so usually we recommend you taking a doctor's visit, and we recommend it coming as a couple.
Okay.
Yes, this appeal to the men. They don't tend to show up.
Yes.
But I recommend you come in as a couple. So that we could see evaluation on both sides. So usually I take a history to find out how long you've been trying.
Okay.
Have there been any pregnancies in the past? You know, if they have, what were the outcomes? Okay. Did they end up in deliveries, end up in a miscarriage, or you actually terminated yourself because you're not ready? Or poor timing, yes. Then we'll find out about your pre-existing medical problems.
Okay.
Blood sugar issues, blood pressure issues,
Diabetes.
Allergies, maybe autoimmune diseases, anything that you have. We'll look at previous surgeries that you had. Maybe some had fibroid surgery, some had laparoscopy for tubal issues or something in the past. And look at any medication you are taking at the moment. And then we'll look at if any prior investigations have been done. Because sometimes the couples tend to move around a lot. Maybe with this facility, I didn't get anything moved. And so this if and what were the outcomes? That's usually that's where we'll start from. And then we'll look at the sometimes you find that the only cause is the intercourse is not even regular enough. That's the only.
I see.
You realize that they are worried, but you realize that sometimes because maybe they live apart. Or the pressures of life, you know, so ovulation and timing, and it's all difficult to follow. So they'll look at the frequency of intercourse. We'll look at if any of the couples do have children aside this union, maybe pre-existing or previous children from other marriages or relationships. So that's the initial history evaluation. And on examination, you look at the gender build, if they are obvious reproductive or maybe issues with regard to their maybe with their PCOS, body hair, facial hair, all those. So you examine that as well. Abdominal exam, are there fibroids, is the womb enlarged, you know. Then if we do a follow-up ultrasound scan to assess the womb as well, we assess the tubes with we are called the hysterosalpingo HSG or laparoscopy to see if the tubes are open. In our evaluation, when tubes are open, we presume it to be functional, but we could be wrong, because most of the tests assess for tubal patency, not tubal function.
Patency.
Yes. Okay. So once they are patent, we presume it's functional.
Okay.
That's what they do. So we'll look at tubal patency. Then we'll look at if ovulation. We'll test if ovulation is happening. Okay. So you may use your previous cycle, and then know about your menstrual history as well, as in how regular are your cycles, how many days do they come for, are they bleeding in between the cycles, all those, they're all part of the history for the woman. And then maybe the man will do a semen analysis initially. If there are problems, we'll go further, do a hormonal assay for the man to see. But those, in a nutshell, those are the main things that we assess.
So you spoke about the regular sex. I'm quite interested in that one, because we can see some ladies who maybe weren't really expecting to get pregnant, and just once they get pregnant, then let's say a couple, maybe you have sex like maybe twice a week. To me, I would think that is regular enough. How regular? Why is it that some?
Okay. So what happens is that what we know is that the gametes, the sperm can last 3 to 5 days inside the reproductive tract of the female. The egg can last 12 to 24 hours. Okay. And the chances of conception or fertilization is higher if there's already sperm present waiting before the egg comes out. Ovulation occurs. So the highest chance of getting pregnant comes if intercourse is happening maybe a day or two before the expected ovulation time. Now, because of the short life, quote unquote, of the egg, if you miss the means, you're going to for another 30 days. That is what brings us down to the regular. Regular, which translates to 3 times a week on the minimum.
Minimum.
That's every other day.
Every other day.
Because assuming, let's say, you are ovulating on, let's say, Thursday, intercourse on Monday, 2-3 days, or 3-5 days. 3 days average run for sperm. By Wednesday, whatever is there is gone. Most likely. you ovulate on Thursday, there's nothing.
Sure.
Intercourse again on Saturday. So for that month,
it's gone.
it's missed.
That's true.
So the regular is the catch. And with those who have sudden unexpected, yes, it's all about timing. If you ovulate and the sperm ready waiting, yes, you might likely fertilize.
Definitely. That's true. That's very true. Okay, so let's talk about stress with regards to infertility. We know that since you mentioned that after most times infertility is kind of treated after 12 months, or you diagnose that after 12 months. Let's say a couple has been trying within that 1 year, that 12 months of waiting, and definitely with the anxiety and all, it can cause it can cause psychological stress, emotional and all. I want to know if stress it's a factor of infertility.
Yes, it can be a factor in the sense that stress can affect hormonal balance hormonal levels. This in both male and females. So obviously with that you could have ovulatory challenges, or even for some men erectile issues as well. So usually that part is taken care of by psychological counseling, which is a very integral part of our assessment as well. Aside the history examination, the counseling part is important, so that it helps alleviate it. So you know that, okay, well, I might not be the only one with this, and then with time it will happen.
Sure.
So usually it comes after maybe family pressure, be married for long, pressure for maybe in-laws. There are multifactorial reasons why it happens. Couples get stressed, but usually it's the women are the most stressed ones.
Yes, they are.
So, but yes, the counseling should take care of that. And then reassurance. Once they get to know that, okay, usually it reduces.
It reduces a bit, and before you know it comes again, though. Yeah, I think women are usually more anxious. Apart from even the in-laws, the society, you start thinking, oh, what will this lady be thinking about me and all that? But I think it has to do with the mutual, you and your partner, if you are ready. And well, at times some partners are not, they don't help to. Some men don't help to. So you've talked about the timing. This one, I don't know. Okay, well, I want to just ask this. Does the position of a sexual intercourse matter in terms of fertility?
It's more of a myth.
Funny. Okay, it's
more
myth.
of a myth.
Okay, so it should be clear.
Once you have sperm there, once viable sperm, emphasis on that, and you have potent or good eggs, you are likely to have conception or fertilization at least. Usually what happens is that the position and all those, because even it doesn't really matter.
Oh, okay. It doesn't matter.
It's not really a big
thing. So
it's
a myth.
It's a myth.
Yeah, it's not a fact. Okay, it's good that it's been cleared. Yeah. So we are wrapping up. We were talking about the treatments. We would leave the assisted. You talked about the assisted form of infertility treatment of
conception technique.
Conception technique. That we'll talk about it on its own. What are some of the treatments that can be given to a lady during infertility?
Okay. So as I said, our evaluation usually involves the man and the woman, so the couple as a whole. So the treatment is directed at the cause, if ever some is found. So if it happens to be, let's say, an ovulatory problem, usually you would have had tests that will show that, okay, maybe in your previous cycle you're not ovulating.
Okay.
So you can give you ovulation induction medication. It could range from pills or tablets to injections.
Okay.
Given usually within the first 2-3 days of your start of your cycle.
Okay.
And then hopefully that would cause you to ovulate.
Okay.
And then once you ovulate or you're about to ovulate, they'll test to confirm or check, then you can time intercourse with it.
Okay.
That presupposes that all other factors have been taken care of, and ovulation or anovulation is the only cause.
Sure.
If it's a tubal factor, where tubes are blocked, then you might have to do an assisted conception technique.
Okay.
Because a blocked tube might not be so functional. in terms of picking up the tube, fertilization,
Okay.
and all that.
Okay.
So
Yeah.
it's a better route to use an assisted conception technique.
Okay. Okay.
If it happens to be, let's say, a womb problem, where there are fibroids or endometriosis, usually we treat it probably surgically, take care of it a couple of months later before you come and plan trying to conceive. So it's taking like 2 or 3 parts in terms of treatment.
Okay.
If it happens to be the male factor, depending on sperm quality, you may need further assessment to see why is it low, maybe a DNA sperm check to make sure that the DNA of the sperm also not compromised. Once that is corrected, then you can be on medication for a minimum of 3 months, and then a new semen analysis will be done to see if it's improved or not. It depends. If it's a low sperm count, treatment over minimum 3 months, sometimes it could be 6 months or even more, could work. If it's a no sperm, as in 0,
no sperm count at all,
yes, then that one, an assisted technique probably with a donor sperm will help. If it's okay with you, you are counseled towards these things.
I see.
And then you agree and sign consent forms for that as well.
I see. You signed the consent forms here to avoid.
Exactly. So those are the options generally.
Yeah. Okay. So in wrapping up, what would be some of would you suggest as some preventive measures, for infertility for women?
Well, I think one of the big things for women is a tubal factor or tubal disease from pelvic inflammatory disease or sexually transmitted. So I think that for young women yet to have babies or yet to get to reproductive age, well, they're in a age all right, but yet to get to the point where they desire to conceive. Yes. It will be more prudent to have maybe a healthy or more responsible sexual behavior and habits, particularly with the make sure that they don't get STIs, STI prevention and all that. Sex education with safe sex practices is very important for that age group. Because that seems to be the biggest thing affecting their chances. Things like ovulatory problems, PCO, you have
really
little
not
control about that. So that one, yes. And then it also depends on who you meet. You could be very fertile and meet a partner whose sperm is
low or none at all,
not good enough. So it depends. But everybody should be more responsible towards. So I think safe sex, lifestyle, more responsible behavior, sexual behavior from the adolescent to the early adult stage. It's very important.
Yeah, so I think it should really start from the adolescent, because then I think ladies or even you individuals can be quite reckless at that age, not thinking of let's say 5 years. Thank you. 5 years time when you are now ready and then you are having issues. So we should start from the adolescent age to be responsible. That's very true. Thank you for honoring an invitation and for giving us a bit of your time from your tight schedule, and we know you would always be available for us. This has been Ladyz Digest, and we were discussing infertility in women, and we talked about from the diagnosis to the treatment and a bit preventive measures to this condition. You can always go back and watch on our social media handles at Ladyz Digest on Instagram and Facebook and YouTube at the Association of African Universities. I'm Joan Ekuyayu. Many thanks to my production team for making this production a success. Till we'll come your way next time. Bye.